All right, welcome everyone to today's NLA webinar on an exciting new advancement in the treatment of high triglycerides and the prevention of acute pancreatitis. My name is Regis Fernandes from the Mayo Clinic, Arizona. I'm honored to be your host for this important discussion, along with my colleague, Dr. Susan Halli Demeter. As many of you know, elevated triglyceride levels are a major risk factor for cardiovascular disease and can also lead to life-threatening conditions like acute pancreatitis. Finding effective treatment has been a long-standing challenge, and today we'll be diving into one of the breakthrough therapies that have the potential to transform the way we manage triglyceride levels. In a previous journal club, we discussed the results of the BALANCE trial of Plozasiran in acute pancreatitis and familial hyperchylomicronemia syndrome. And today we'll be talking about the PALISADE trial, which is the trial of Plozasiran or Plozasiran, as you wish, for managing persistent chylomicronemia and pancreatitis risk. We're thrilled again to share insights on the science behind these therapies, its clinical applications, and what it means for patient care. We're going to have plenty of time for a Q&A session, so feel free to submit your questions through the chat throughout the webinar. And thank you for joining us, and let's get started. Here are some of the learning objectives. We're going to discuss the results of the PALISADE trial, describe the clinical applications of the findings. At the end of this talk, you're going to be able to identify new targets for lipid-lowering therapy and understand the mechanism of action, application, and differences of these novel therapies for triglyceride reduction. We have no disclosures, neither Susan and I, for this webinar. A little bit of background here. So hyperchylomicronemia is a genetic disorder, as you know, with familial chylomicronemia syndrome, FCS, being the classic form. FCS is a very rare autosomal recessive disorder, but some patients with a more common type, multifactorial hyperchylomicronemia, which is more likely what you're going to find in clinical practice, are phenotypically very similar to FCS. The important thing is that both of them can exhibit high levels of triglycerides and can be associated with the risk of pancreatitis, regardless of the genetic test. Another important background is understanding ApoC3 as a significant target. ApoC3 is a major plays an important role in triglyceride metabolism. There are three main mechanisms. It inhibits LPL activity, inhibits hepatic uptake of triglyceride-rich particles, and then on top of that, stimulates hepatic production of the LDL. So targeting ApoC3 has become a key therapeutic approach for managing hypertriglyceridemia. So a recent trial of Plozasiran, which is an ASO, we'll be talking more about that later, had demonstrated a significant reduction in triglyceride levels in ApoC3 and decreased risk of pancreatitis. So at the end of last year, the FDA approved Plozasiran, known today as Tryngolza, for reducing triglyceride levels in patients with familial hyperchylomicronemia syndrome. So the PALISADE trial that we're going to be talking today was a phase 3 clinical trial that involved randomly assigning 75 patients with persistent chylomicronemia, with or without genetic testing, this is very important, to receive either Plozasiran, which is a siRNA that reduces the production and secretion of ApoC3, or placebo. The treatment was administered every 3 months for 12 months. Primary endpoint was the mean percentage change in triglycerides, and a secondary endpoint, incidence of pancreatitis. So now I'm going to let Susan talk to us about the entry criteria for this trial, which is very important.
Thank you. So patients had to be, the inclusion criteria included patients at least 18 years and a diagnosis of severe hypertriglyceridemia that was resistant to standard lipid-lowering therapy. They had to have documented history of fasting triglycerides of greater than 1,000 on at least 3 occasions. And then they had to have one of the following. And this is to note that first, genetic diagnosis of FCS, which was almost half of the patients. But you can see not all of them had the confirmed genetic diagnosis for this study. Next was absent or low post-heparin lipoprotein lipase activity, which was less than 20% of normal value, and that was exhibited in 2 of the participants. History of acute pancreatitis not caused by alcohol or cholelithiasis, which was 45% of the subjects. Recurrent hospitalizations for severe abdominal pain without another identifiable cause, which was 1 patient. Then there was childhood pancreatitis and family history of hypertriglyceridemia-induced pancreatitis, which was 1 patient. The exclusion criteria included uncontrolled diabetes, use of corticosteroids or anabolic steroids, and chronic kidney disease. Next slide. So with the study design, so after screening, labs, medications, and then achieving dietary stabilization, the 75 patients were randomly assigned within an 8-week period in a 2-to-1 to 2-to-1 ratio to receive either 25 milligrams of plozasiran or placebo, or 50 milligrams of plozasiran or placebo every 3 months for the 12-month treatment period. The randomization was stratified according to triglyceride level, whether it was below 2,000 or greater than 2,000. And patients who completed the blinded phase of the trial were given the opportunity to enter an ongoing extension phase of open label plozasiran. Labs and lipids were assessed immediately before each injection and monthly thereafter, after achieving 10 hours of a fasting state. The primary endpoint was placebo-adjusted median change in triglycerides at month 10, and the multiplicity-controlled key secondary endpoints included % change from baseline at months 10 and 12 averaged in fasting triglycerides, % change from baseline at month 10 in fasting ApoC3, % change from baseline at month 12 in fasting ApoC3, and incidence of positively adjudicated events of acute pancreatitis during the randomized period. And to note that the study protocol was amended to stipulate that subjects who did develop acute pancreatitis, they could be transitioned to then the open label plozasiran group. Next slide, please. This just goes over some of the demographic and clinical characteristics of patients who participate in the trial. And you can see in the 3 arms, the age range was similar in all 3 arms. 51% female participants, 73% were white. The median triglyceride level was 2,044 milligrams per deciliter, and the range was anywhere from around 1,300 to just under 3,000. Please note, too, that just less than half of them were receiving a statin who participated, and 63 to 73% were on a fibrate. About a quarter to a third were on an omega-3 fatty acid, and about 30 to 45% had diabetes or prediabetes. You can see that several were taking metformin, and around a half received insulin, and also that a half to 2/3 had genetically confirmed FCS, and most had prior episodes of pancreatitis. I'll turn it back over to Dr. Fernandes.
All right, thank you, Susan. So let's take a look at the results of this trial. So this slide showcases the mean triglyceride percentage change. If you look here on this axis, here's the percentage of reduction. You can see that it's definitely over 50%. It gets closer to 80% reduction at month 10 and 12 for the different dosages that were used. We can also see a significant reduction in the ApoC3 level, paralleling the results, the % reduction of triglyceride here, getting into the 80% or even 90%. So significant reduction in triglyceride level as a result of significant inhibition of ApoC3. This shows the change of triglycerides and ApoC3 over time. You can see here that between month 0 and 2, there is already a significant reduction in that triglyceride that kind of persisted throughout the time, and again parallels the drop in ApoC3 over time. I think what's interesting in this study is that the reduction happens at around 1 month here, and then it persists for 12 months. Clinically important. This slide here shows the results in patients with genetic confirmation and without genetic confirmation, which clinically for me is very important. You can see there is not a significant difference about this. So with or without genetic confirmation, you get a significant response in triglyceride and ApoC3 at the same level. This is a secondary endpoint of the study. So it shows the incidence of pancreatitis over 1 year. So what the slide is showing here are the event-free pancreatitis here. So you can see the patients on the study drug were event-free more than patients that took placebo. But here on the right, you can see better the breakdown. There are about 7 incidences of pancreatitis in the placebo group and only 2 in the Plozasiran group. So it's a difference between 20% versus 4%. And it was statistically significant with a good p-value. In adverse events, some interesting things to point out. First, the serious events were more common in the placebo group than Plozasiran. But overall, the drug was very well tolerated. A few things that are important to point out here. First, interesting, incidence of COVID-19 here was more in the drug than in placebo. Now, in previous trials of the same drug, that pattern was not seen. So I'm not sure how to explain that, but it was noted and is documented, and it's there for you to see. Another issue is the platelet count. Previous therapies with a different mechanism of action with ASOs have had issues with thrombocytopenia. It actually blocked one ASO drug from being approved by the FDA a few years ago. So here, this drug shows no change in platelet count. Another interesting finding here was the increased levels of ALT. Clearly a difference here, a little bit higher in patients on the drug than placebo, but this you can see here with 50 milligrams, a little bit more here with 25 milligrams, not so much with other factors here, but interesting to notice. In a previous trial of the same drug, there was also a slight change in ALT for a higher level, not as much as in this trial, but not so much in AST and any other parameters. Another important thing is the blood sugar and hemoglobin A1C. So it's a little busy, this slide here, but hyperglycemia did occur in some patients in the study group, more so in the patients that had pre-diabetes at baseline. So patients that had pre-diabetes at baseline, with a hemoglobin A1C more than 6.5, they did have a higher increase in blood sugar comparing to the placebo group. But the mechanism of this is not very clear, but probably is related to the enhanced hydrolysis of triglyceride-rich lipoproteins, which leads to increases in hepatic gluconeogenesis. So that is more likely the mechanism, which was seen in other trials of the same drug. This effect was not really seen or not very strong in patients that were not diabetics. Some of the limitations of this trial: small size, of course, a short follow-up, just 1 year. But one limitation, which I think is an advantage, is that no genetic testing on the basis of findings that patients who meet criteria for symptomatic persistent hyperchylomicronemia have recurrent pancreatitis. So the complications and the morbidity and mortality is the same. But there was no genetic testing for only half of them had genetic confirmation. let's dive a little bit into the mechanism of action of these new drugs. So ASOs, or antisense oligonucleotides, and the small interfering RNAs are new or novel therapeutic drugs that are being used more and more in lipidology, and also other areas in medicine and in cardiology. But in lipid metabolism, these drugs find perfect targets, because basically what they do in a nutshell, they're gene silencing therapies. So both of these are able to block the production of something that you do not want. So in the case of inclisiran is PCSK9. In this case here is ApoC3. Okay. ASOs and siRNAs are a little bit different in the way they work. ASOs work in the nucleus of the cell, is a single-stranded DNA. siRNAs work in the cytoplasm, but the overall goal of these two drugs is to block messenger RNA from building proteins. So we call gene silencing therapies. So very exciting because you can find different targets. Here's an example of the targets that can be used in lipidology with this technology. NGLPTL3, which is another important component or target for the triglyceride and LDL metabolism. A lot of the drugs that are coming out now for lipoprotein A are ASOs or siRNAs. ApoC3 we just talked about now, and here's our inclisiran in PCSK9. So we can see how ASOs and siRNAs have a niche in lipidology and will continue to do so. So in summary, plozasiran is a siRNA therapy that significantly reduces triglycerides and ApoC3 level, leading to a decrease in incidence of acute pancreatitis within a year for patients that have persistent chylomicronemia. The drug was really well tolerated, did not have significant adverse events, to my view. And in contrast with the olezarsen trial, the difference here is that a more broad population without genetic testing was allowed to participate in a trial, which is what we more often see in clinical practice. And in my view, it offers the clinical application of this trial, in my view, is that we can use this therapy for patients that don't have genetic confirmation of hypercholesterolemia, but they present with triglycerides over 1,000 and they have acute pancreatitis. And we have a lot of those out there. So I'm going to end here and open the forum for questions in the chat. I hope we got a lot of questions. Do you see it?
Or if anyone joining us participated in the trial, I'd love to hear your experience as well.
Would love to hear anything about this trial.
I have a question. In the patients who were diabetic or pre-diabetic, who were on anti-diabetic medication, you mentioned that the hyperglycemia might be due to the liver gluconeogenesis. So does it matter based on the type of medication category they were on, like GLP-1s that do help suppress that versus just insulin, if that question makes sense?
I think it does, yeah. So the answer may be a little complicated, but in this case here, it has to do with the increase in this triglyceride availability in order to interfere with glucose metabolism and gluconeogenesis by the way it affects glucose and lipid metabolism. Different drugs may have different effects. I think with olezarsen, we have to see if there was an increase in blood sugar. It'll be interesting to see because it also has kind of the same effect. You're blocking ApoC3. As far as GLP-1s, probably a completely different mechanism. I think it'll be more interesting to see if the ASOs and siRNAs, in this case, by blocking ApoC3, will have the same effect on glucose metabolism, and I believe they do. Lots of questions coming through. Let's see effect on ApoB, this trial and compared to the other ASO. It was very similar because ApoB obviously will go down because chylomicrons are going down, and some of the VLDL goes down too. So obviously the effect on ApoB will be represented, but because of the small effect or negative effect on LDL, you're not going to see a robust drop on ApoB because most of the ApoB is determined by LDL. But because of the VLDL reduction, you're probably going to see a decrease in ApoB. As far as the chylomicrons, probably not much. Chylomicrons are also measured when you do ApoB, but because they are ApoB48 and they don't last very long after digestion, they don't circulate for very long. But in these patients, they probably so. But the effect on ApoB was not robust, but it decreased in both. The cost of the medication, I do not know.
I don't know either.
But
I think it would depend on the insurance too, you know?
Mm-hmm.
Yeah.
Yep.
What it'll cost the patient.
Could you please show the efficacy in genetic confirmed versus not confirmed again? What is the clinical significance of the efficacy? There was no difference, and I can show the slide again, but there's really no difference in the efficacy. And that's the beauty of, that's what I found was interesting about this trial, because the effect on triglyceride lowering was the same. And pancreatitis too. Clinical significance of the efficacy findings. Well, the efficacy was robust, 80% drop in triglycerides. So I think that's what you can expect. Clinical significance is, you can imagine, have a patient with triglyceride of 1,000, more than a 50% reduction will bring below 500, significantly decreasing the risk of pancreatitis. And the entry triglyceride, the average triglyceride in this trial was actually 2,000. So patients were brought to 1,000 and still decreased the risk of pancreatitis, just showing how important it is to decrease that risk. Let's see here. Any effects on LPA? No. No reported effects on lipoprotein A on this trial. Why did the study not mandate statins and or fibrates to maximally tolerated lower triglycerides before enrolling the study? No, I believe the entry criteria did include patients that were already on maximum therapy, tolerated therapy. Mm-hmm. That's usually the entry criteria for these trials. Yeah. You have to exclude secondary hypertriglyceridemia, and you have to be on maximum tolerated therapy. Is that correct, Susan?
Yeah. Mm-hmm.
If you are gotta ask, you can't afford. Okay. But I make comments in there. Do you think you want to take this one, Susan? Take one in there, and I'll.
Let's see here. Oh, how it compares to volanesorn. Well, I know there were the platelet issues with volanesorn and the decrease in platelets, but they didn't see that, with Plozasiran. So I know that was one difference, as far as safety from that perspective. What 12-hour fasting triglyceride would you accept as abolishing the risk? I guess, that depends, on the patient and that. I mean, we know, like with the triglyceride, recommendations, with trying to achieve triglycerides below 500 is what we're always trying to, achieve best we can with our patients. Do you have anything else to add with that, Dr. Fernandes?
No, I think.
Yeah.
I think we're doing great with time, so I think we're going to be able to answer all of them. I'm just going one by one here, Susan. Here's a good one. Do you think it's possible to use this for children, as it is very difficult to control their triglycerides? I know it is not licensed, but Repata is not either, and it's being used as last-ditch trial for younger children in practice. Well, yeah. So again, clinical trials were done in adults. I hope that in the future they do that.
Yeah.
This was done recently with, I think, Evkeeza, right? It was initially shown to have a significant effect in adults, and then they did it in children because it's for patients that have homozygous FH. So homozygous FH, you want to treat very young, and they did tolerate the medication very well. Now, there was a monoclonal antibody. It's not an SO or a siRNA. So using this technology in children, it will be challenging in a way that you really want to have a trial or a study showing that there's no effect. I think it'll be important because of the mechanism of action. Now it's different. But monoclonal antibodies for NGLPTL3 were shown to be safe in children, right, Susan? I think was fine.
Yeah, down to age 5.
Thank you. Differences in balance and bridge in ApoB. Exact opposite effects on ApoB in those two trials. Well, I'm not familiar with the bridge trial, but I can pull it out and tell you the difference. Do you know anything about it, Susan? I'll look it up. We'll get back to this one. Can you give us an idea of how it compares to volanesorsen? Why 12 hours fasting triglyceride would...
That one we answered already.
Oh, okay. Sorry. Sub-analysis with and without fibrates. Yeah, these patients were on maximally tolerated therapy, which included fibrates and anything else you can throw at them. That's usually the entry criteria for these trials, which have not been shown to be very effective. I mean, they do lower triglycerides, but there is no data showing that fibrates reduces the risk of pancreatitis. Let's put this one. Can it be administered concurrently with other lipid-lowering therapies? Good questions. I believe it can, just like you use inclisiran with other therapies. But you don't use inclisiran with a PCSK9 because they have the same target. As long as the other lipid-lowering therapies are not targeting ApoC3, I think it's game, but yet to see.
Yeah, you can use it with other.
Increases LDL? I don't think it increases LDL. In a previous trial of plozasiran, we can pull it out here, but plozasiran also published a trial last year on patients with mixed hyperlipidemia and plozasiran. And I think there was a reduction in LDL. We'll have to go back and see. There was a reduction in ApoB and a reduction in triglycerides, ApoC3. But we can take a look because they look at HDL went up, but I believe LDL went down. We can look at that. They did not look at that in this trial. All right. General specific target for siRNAs and ASO agents in general. They are specifically targeted for hepatocyte uptake, which helps them to be very specific for effects on hepatic gene expression. The efficacy is really impressive with infrequent injections. There are some ApoAs lowering, just like I showed in that slides, other targets in late stage development. Novartis is a company among with others. Okay, not really a question, but kind of a comment and a good comment showing the potential future for this type of therapy. Volanesorsen is an older generation and doesn't have the liver specificity, so it is giving at much higher doses, resulting in safety concern. Yes, that's correct. So volanesorsen is an ASO that was used for targeting ApoC3, but it did affect platelet counts. So what the company did was to add, I forgot, it's a guaianac something, Susan, which is it's a molecule that specifically causes the drug to enter the hepatocyte. So it makes it very liver specific, so it does not affect bone marrow, etc., or other areas. So no thrombocytopenia with that. So that's the problem. So volanesorsen has been abandoned as far as I know, because of that. If average baseline was 2,000 and plozasiran reduced by 50, it was more than 50. Triglyceride level of 1,000 is still not at goal, correct. What is your opinion on options for getting these patients to goal? Well, one option is to find drugs with different mechanisms of action. For instance, NGLPT-L3, just as an example, right? So different target that also lowers triglycerides, and it can be knocked out with ASOs or siRNAs. So maybe that's how we're getting to the future, combining these drugs with different mechanisms of action that have very target therapy to be able to achieve your goals on these patients. I think that would be the best answer.
There was also a comment in the article for further study too. You know, there's a big part with the very low-fat diet and adherence. And, you know, the patients for the year had to be adherent. But, you know, what will these results look like if people were struggling and were not always adhering to the very low-fat diet? And looking at that, and that, I guess, will kind of reveal itself with time. And something, you know, to be studied. And that's always something that has to be reviewed and discussed with your patients when you're meeting with them. You know, are they exercising? Are they following a very low-fat diet? And then, you know, using the other meds we know in our toolbox, you know, to treat high triglycerides. I did have a patient who participated in the BALANCE trial. This was, you know, it's amazing. I have two patients with FCS. And the one was able to participate in the BALANCE trial and is still on it. And her triglycerides, you know, were always in the 2000s, recurrent pancreatitis throughout her life. And now her triglycerides are just under 400. So it's pretty amazing, you know, how well these medications work. And that she has less pancreatitis. You know, she hasn't had any significant pancreatitis spells since.
I'm looking at this article here from Mendel. Evinacumab in severe hypertriglyceridemia with or without LPL pathway mutations. Okay, take a look at that.
We may be able to give everyone back some time. I don't see any other comments.
Yeah, of course. Yeah, it's wonderful to share and exchange ideas with all these lipid lovers. 72 participants with great questions. Thank you, Sheila.
Thank you.